CLL nowadays is treated differently because 10 years ago it was treated by means of chemoimmunotherapy. We were combining rituximab plus fludarabine and cyclophosphamide. This combination has a lot of side effects and a tremendous bad effects on the bone marrow. However, nowadays our patients are treated by a different way. It is a novel notion. We approach the patient differently by making a genetic profile, genetic testing. Because this patient, the newly diagnosed CLL patients are tend to have a karyotype, a flow cytometry. Flow cytometry is important to check for B cell markers and ZAP70. ZAP70 carries, a bad prognostic factor or bad prognostic impact of the patient. Then we make a karyotype to check for chromosomal abnormalities or chromosomal aberration, like deletion of 17p. Then we make an NGS, next generation sequencing, or Sanger sequencing to check for TP53 burden. TP53 is allocated to either high burden and low burden. In case of high burden TP53, it means that the risk is very bad, and the response to even new drugs targeted therapies such as PCR inhibitors and BCL2 pathway inhibitor gonna be very bad. So most patients, newly diagnosed patients, represent with 5 to 10% of TP53 mutation at diagnosis. This percentage can be greater in case of relapse, or in case of usage of chemoimmunotherapy. It may increase to 30 to 40%. This percentage also gonna be more. It can increase to 50, 60% in case of Richter syndrome. Richter syndrome is caused by subclonal and clonal evolution and expansion. So, now the combination of chemoimmunotherapy in case of TP53 mutant is forbidden now, because it leads to clonal expansion and relapse and refractory disease, and consequently it's gonna worsen the response and shorten the progression for survival and the overall survival. So in case of B53 non-mutant, deletion of B negative, we may give the patient, Ibrutinib 140 milligrams for 3 times daily in continuous till disease progression or resistance, or in case of TP53 mutant, and combined with deletion of B17, we can give the patient anti-BCL2 Venetoclax plus Obinutuzumab. So every patient is encouraged to make TP53 test by next generation sequencing. We should be aware the physician first to collect a very good sample, because in order to get a good result on NGS, we need to get a sample containing at least 90 to 95% of malignant cell.